Welcome back to part 2 of our knee OA and total knee arthroplasty, or TKA. We don't need to do much of a review from the first part, but I do just want to remind everybody that what usually leads to a total knee replacement is going to be a breakdown of the cartilage around the knee, which then causes loading to change, and therefore pain and possibly also breakdown of soft tissue and bone beneath the cartilage. So again, we don't need to necessarily go through all of these things again. We talked about ways that you can avoid requiring a knee replacement. And then we also talked about when a knee replacement is necessary. And we went through the technique of the actual knee replacement. Complications, just to remember from the last presentation, DVTs are possible, but they're not seen very often. So if you remember, we went through the prediction rule and we talked about how if the patient's presenting with 3 or more points, that it's more likely that they're at a high risk for a DVT. 1 to 2 points means a moderate risk, and if they do not have any of these criteria, then they're at a low risk for DVT. But we also talked about other complications could be things like infection, which is probably much more common for your patients to present with following a total knee replacement. What also you want to be aware of are precautions. These patients after surgery are typically using some sort of walker, and we're hoping that the doctor is allowing for weight bearing as tolerated. In the United States, patients, unless they had some very significant complications during surgery, are going to be allowed to be weight bearing immediately following surgery. Forward wheel walkers are what are most likely used. That's not always the case in China. I recognize that. We're kind of trying to encourage those forward wheel walkers more and more frequently because they tend to be a little bit easier to allow for mobility. What I really want to spend a good amount of time on today, however, are not only the protocol that we want to use, and there really are protocols related to total knee replacements, but more importantly, the outcomes. As I had said in the previous presentation, total knee replacements are something that pretty much in any type of therapy setting that you're in, you're going to see a lot of these patients following this surgery. So very, very common. And unfortunately, even though we have a lot of research behind this surgery, we have very, very good surgical techniques, our outcomes, you'll notice, are not really incredible. They're not as good as I think they could be. What the primary outcome that we see for patients following the surgery is pain relief. And so these patients have had pain for a long time. They've attempted conservative treatment. They've probably worked with us as physical therapists. And what they truly needed was a replacement of the joint. And so what we find is that 90% of our patients are going to report a lot of decreased pain. They also will report that they're able to get back to their functional level. But what we actually find when we measure these patients 2 to 3 years later is that they're still very limited in function. So they've not returned to previous level of function, even though they think they have. What has happened is that their pain relief is so much better that they think they're functioning better, but it tends to be decreased function. And so we want to, as therapists, really consider this and try to improve on our outcomes as much as we can. The other thing I think is really important to be aware of is that range of motion at 1 year is actually pretty good for these patients. So what we as therapists tend to do is focus way too much of our time, of our treatment, on improving range of motion. Whereas you're going to find that generally, most of these patients have at least 110 degrees, up to 120, 125 degrees of flexion 1 year after treatment, or 1 year after surgery, even if very little treatment has been done for range of motion. And so, again, this is a functional improvement. And we want to make sure that our time is not focused on range of motion, but instead focused on the things that we're going to talk about today, which include improving overall function, which includes strengthening, neuromuscular reeducation, those kinds of things. So what they found is that these patients after surgery have long-term deficits in strength and function compared to their healthy adult counterpoints. So patients of the same age, the same socioeconomic class, and those things are demonstrating much better function than our patients who have had a knee replacement. They tend to show 40% deficit in quad strength, as well as a 30% deficit in their walking distance, so how far they can tolerate walking, and a 50% deficit in stair climbing speed. So they're still showing that they cannot climb stairs as quickly as their matched counterparts. And so this can be discouraging, and we need to really consider how we can improve on our outcomes with these patients following a knee replacement. As I said earlier, one of the big things that happens is that we spend our time focusing on knee range of motion, especially knee flexion, and that is not the most appropriate treatment strategy. These patients will get back the knee range of motion. During the first couple weeks, swelling is what is limiting knee range of motion, so we just need to wait till the swelling goes down and range of motion will increase. What we do, however, need to focus on is quadriceps strength, because that is directly related to functional performance. And it's not so much that these patients have muscle loss, but that they actually have what are called activation deficits. So these activation deficits of the quad account for a much bigger problem in weakness, what we would call weakness, and as we said, ability to perform stairs, ability to walk more quickly. And that's much more an issue than actual atrophy of the muscle. We also do need to consider knee extension range of motion following surgery. What I'm sure you've seen is that a lot of your patients who have knee OA are not able to tolerate knee extension because they've lost strength, they've lost quad control. And so over years of changing movement patterns, they don't have full knee extension anymore. And so in a conservative setting where they haven't had surgery, you can spend a lot of time working on knee extension. Some of your patients will be able to then achieve full knee extension, which is great, with us training quadricep muscles, doing some knee extension mobilization. That's what we're hoping for. Those patients, however, that are not doing well with conservative treatment and end up having knee surgery for a knee replacement, they're coming to us and they still continue to have decreased quadricep contraction and likely have decreased tolerance to full knee extension. So we do need to actually work on knee extension range of motion, but not necessarily just to achieve extension, but to achieve it with quadricep contraction. And so you can see here, this is just a picture, sort of a visual way of thinking about these patients' quadriceps after after surgery, that their strength loss is primarily coming from activation deficits, meaning they don't know how to turn on their quad. This is the big problem, is that their muscle has not probably been used for many years. And now that they've had surgery, we are dealing with even a bigger deficit in the ability to activate that quadricep muscle. So it's not so much that they've lost the muscle, but that they're not understanding how to turn it on. So there's lots of research out there to talk about different ways we can improve activation of the quadricep muscle. I'm not going to go into detail on this particular research. It's from the Physical Therapy Journal, and you'll have that reference in the references. But what I want you to recognize is that NMES, neuromuscular electric stimulation, is one option for helping for increasing quadricep contraction and activation. And this research found that adding NMES within 48 hours of knee replacement surgery, and you'll see here they've set it up where the NMES has pads on the quad, and the patient is asked to attempt to extend the knee against the little strap there on the bottom. And if they can, when they feel the electricity of the NMES, then push against that strap to turn on their quadricep themselves, then we're actually getting a better quadricep activation contraction. And so these patients in this particular study were told to perform NMES in the clinic, in the hospital setting for several days, and then they were also performing it 6 sessions at home, and then 10 to 12 sessions in outpatient therapy. So they were doing a lot of NMES 2 times a day during this treatment time. And they found that their functional outcomes were actually better using NMES than the group that did not actually use NMES. And that function improved in the timed up and go, the 6-minute walk test, and other functional measures that were used. Another research article out of the Physical Therapy Journal, I believe. No, I'm sorry, this was JOSPT, so Journal of Orthopedic and Sports Physical Therapy. They used 2 different protocols, if you will, where they used NMES, but then they also did more high-intensity exercise, and then the control group did more traditional strength training type of program. And what they found here, this is sort of going through what the study looked like. Again, this was done by Bade et al. In 2011. The traditional training program did functional training and some resistance exercise with resistance band and weights. The high intensity actually progressed to higher level functional activities a little faster, including eccentric training techniques. And so as we go through our protocol today, we're going to actually use more of this high intensity exercise protocol to talk about how we're going to progress our patients. Basically, they were increasing body weight activities earlier and all of those things. And what they found that between the control group and the high intensity group, there was no difference in pain or range of motion, but you'll see that their functional outcomes did improve in the high intensity group much more quickly. So these are just a couple of figures here. The first one is with the stair climbing test. And they did the stair climbing test before surgery in both groups, and then 3.5 weeks after surgery, all the way up to 1 year after surgery. And what they found was that the time that it took to climb stairs in the high intensity group was significantly less than the time it took in the control group. So you'll see here at 3.5 weeks, they were already climbing stairs in under 25 seconds, whereas the control group was taking 40 seconds. Another thing they tested was the timed up and go, and this is again a timed test, and they found that at 3.5 weeks, it was taking about 8.5 seconds for that high intensity group, whereas the control group was taking almost 14 seconds. And those types of improvements continued up to 1 year. And the last one we see here is the 6-minute walk test. And so you'll see pre-operation, the control group was actually a little bit better, but post-operation, the high-intensity group was able to perform 400 meters in 6 minutes, whereas the control group was only able to perform about 300 meters. And that continues to improve throughout until the 1 year mark. So again, this idea of pushing people a little bit harder, the way that we're going to go through the protocol today, does show better functional outcomes. Another thing I just want to bring up is this idea of preoperative treatment. I know that that's not very common in China, but outcomes also improve when there is some sort of preoperative class. That doesn't have to be one-on-one treatment, but this idea of educating your patients on how to use a forward wheel walker, what to expect after surgery, where the patient might go after surgery. So this idea of discharge planning, which again is not a big thing in China, we recognize that, but helping patients kind of understand their plan is a nice way for them to mentally prepare for surgery and post-op, and us doing rehab after surgery. So what you'll see here with the time frames, it's going to be a little bit different than the last presentation I gave on the ankle, in that some of these patients tend to be very active. And so this first phase of protected motion, you'll see a 0 to 2 weeks. Some of your patients are going to be out of this phase within several days and actually move on to phase 2 within the first week. Other patients who may have more pain or more history of other comorbidities might go a little bit slower. And so this first phase may take up to 2 weeks. During this phase, we have goals of range of motion measurements of 0 to 90 degrees. So we would like for that range of motion to get to 0 degrees of extension, but we don't necessarily get to that, and that's okay. You'll see that by the end of this phase, if we're not there, it's okay. We would like 90 degrees of flexion, however. We also would like muscle strength to be anywhere from a 3 to a 4 out of 5. And then we would like for them to be walking during the first phase. So it's important that they are walking. Most of your patients will need an assisted device of some kind, but we do want them walking. And then, of course, as I said earlier, we want pain to be minimized, and that's kind of the biggest issue and the biggest reason we might stay in the first phase and not move into the second phase. So during this first phase, we're hoping we can get our hands on a neuromuscular electric stimulation unit, like what we talked about earlier with the research. And again, this is to help with quadricep activation. So we're hoping that that's something that we can use and educate the patient on its use. We're also educating the patient on using an assisted device, as I said earlier, usually a forward wheel walker. We want to make sure they're not putting a pillow underneath their knee to cause knee flexion while sleeping or while spending time in bed. And we're also spending time during this first phase talking about how to get clothes on and off and how to do stair climbing using their uninvolved side. So we do, during the first couple weeks, need them to be able to safely do stairs, but not using the side that they did surgery on. During the second phase, during this first phase, we want to specifically consider our treatment to be focused on pain management, as I said earlier, but also we want to consider how we can make sure that the patient can move around in bed without pain. So bed mobility and transfers are all things that need to be done during the very first day, 24 hours to 48 hours following surgery. So again, unless there was some sort of significant complications, we really need to have these patients up. And in the United States, they're not just transferring, they're actually walking within the first 2 days. So gait training becomes another big part of our treatment. Manual therapy can include some massage and stretching, as well as patellar mobilizations. And then I'm giving you specific exercises here. I'm not going to talk about them in detail. You see the list here. Why we do that is because there are specific exercises that are most appropriate during each of these phases. These are things that we can hopefully go over in a lab. Hopefully we're going to be able to do some post-operative labs so we can go into the details of these exercises. But what we need to recognize is by the end of the first phase, we want to be able to complete, our patient should be able to complete 2 sets of 8 repetitions of this list of exercises without fatigue. So that's kind of the milestone to move on to the second phase. They also should be able to report less than 5 out of 10 pain. And then you'll see range of motion measurements. They're relatively easy. We want them to be able to get to at least 15 degrees of flexion from extension, so 15 degrees before they have full extension, as well as 80 degrees of flexion. So again, that's relatively easy to achieve in sometimes the first couple of days. So the second phase you'll see goes to about week 4. It could start at week 0, it could start at week 1, it could start at week 2. And it's during this phase that, again, we want to make sure we're decreasing swelling, inflammation, increasing range of motion. Pain should definitely be less than a 5. Also, our goals are going to include cycling, so a recumbent bike works best, and we want to be able to bike for 5 to 10 minutes forward and backward. So maybe not going all the way around, having a full revolution of the bike, but being able to go forward and backward at no resistance and being able to tolerate that particular exercise. We also want to be progressing their walking during this phase. And so we are educating the patient that we want to increase that walking distance pretty much every day and start increasing the weight bearing. So as we said earlier, we're saying weight bearing is tolerated, recognizing that the first couple of weeks, they're not going to have tolerance to full weight bearing on their involved leg. And that's okay. The idea is that each day we're hoping they can increase that tolerance a little bit more without significant pain. So treatment continues to be patellar mobilizations, scar mobilizations. You can do some soft tissue work around the quads and hamstrings. You'll notice I do not put passive range of motion here. There are other ways that we can do. We can call this stretching, so that we're trying to get some soft tissue stretching. And then with things like the bike, no resistance, but we're hoping that they can start going around in a circle on the bike as part of treatment at this phase. Again, you'll see a list of exercises here. This is kind of where we want them to be for the 2nd to 4th week after surgery. I'm not going to go over these, but what you should recognize is that to move from phase 2 to phase 3, they should be able to complete 2 sets of 8 repetitions of this group of exercises, this new group of exercises, without fatigue. Okay, so again, we're progressing exercises. You'll see these are a lot more weight-bearing exercises, also some side-lying exercises, and we want them to be able to complete those without fatigue. Pain, you'll see pain's about the same, because again, we're increasing activity level during phase 2, so we're not expecting the pain to decrease significantly. We're also attempting to increase range of motion, so we want them to 90 degrees by the end of phase 2. We want their extension to be about the same, but I'll be honest with you, I'm trying very hard during this time to get knee extension. So I'm using quad sets, I'm using NMES, I am doing some joint mobilization to get that knee extension much closer to 0. Phase 3, you'll see it says week 2 to week 12. This may actually start at week 4. Again, some of our patients are going to progress faster than others, and that's okay. It's really dependent upon how well they tolerate the exercises. So the goals that we talked about of being able to perform these exercises, that's really what will progress them then into phase 3. And phase 3 will last until about the 3rd month after surgery. Our goals during this phase is that we really do want to get to 0 degrees of extension and up to at least 100 degrees of flexion, hopefully to a functional range, so they're able to perform activities in their daily life that look relatively normal, like sitting down on a toilet or going up and down stairs. Our other goals include using an assistive device for as long as they need to so that they can tolerate walking without a limp. So the idea is we're trying to get them away from the assistive device, but if they cannot do so without a limp, then they continue to use that assistive device. If that's a cane, they're still using the forward wheel walker. And we're trying to find ways to increase their cardiovascular fitness during this phase. So the bike might be the best option, but things like walking, swimming, those things are fine as well. So again, we're transitioning from a forward wheel walker to a single point cane to no assistive device during this phase. And we're making sure that the patient understands how to perform gait correctly. So other exercises are going to include some single leg press, maybe on a machine, as well as more extension and flexion with resistance, and then some standing hip exercises. We're also going to focus on the stairs during this phase. So step up, step down, side steps, being able to perform stairs step over step by the end of this phase is ideal. It really is kind of what we would like. We also need to start looking at balance. So we're going to do single leg stance progressions, maybe start to do some different things with squatting and doing those things against the wall as well as in real space like sit to stand. And again, the goal for the end of phase 3 is that they're able to complete all of the exercises listed here, 2 sets of 8 without fatigue. Also at this phase, their pain should be decreased, so they should be less than or equal to about a 3 out of 10. And their range of motion, again, I would say 0 degrees to 100 degrees is your goal for range of motion during this time. And we're really trying to get that range of motion with active activities, not passive range of motion in the clinic. Phase 4 is our functional training phase. And you'll see that some of your patients probably can start phase 4 at about week 6, still going up to week 12. And the reason that we say that is because I know in China, it's not easy to see patients after about 3 months. But if you can see them after 3 months, then you're going to continue with their functional training and return to sporting activities. So it's during this phase that we do want full knee extension and about 115 degrees of flexion. So even for a squat toilet in China, 115 degrees is about right. And that would be the goal for these patients. So we don't need to get to 135 degrees. It's not necessary. And some of our patients really want to push that. And again, the idea is that you want them to be functional when they're discharged. We also want pain completely under control and return to full activity. And so treatment to allow for that is going to really go into a lot of our eccentric activities. So you're going to see we have knee extension, step up, step down. All of these things are going to be eccentric and focused on trying to control the quadricep muscle. We're also going to be doing lunging. We're going to be doing star balance, which again is something we'll probably talk about in more detail during the lab. So star balance, reaching with the lower extremities. We're going to do more wall slides where they're holding the squat for longer periods of time. And then we're going to start doing more agility type exercises and talking to the patient about what they want to return to for sport. So if they're wanting to get back to tennis, then we're going to be doing a lot of sort of lateral side shuffle activities or braiding types of activities. If they are wanting to get back to more like cycling and things like that, then we might be doing different types of activities for that. So again, the idea is return to sport, return to basic life at this last phase that we are likely treating them. Okay, so that is the very kind of introduction to total knee replacement. Again, I am giving you exercises that you can use to help progress these patients through the protocol. But what I really want you to be thinking about is more those outcomes and making sure that you're focused on improving outcomes for these people. Another thing to just touch on to keep in mind is that there's a lot of research to show that within 2 years of a knee replacement on one side, a large percentage of your patients will require a knee replacement on the other side. And this is definitely an issue that we need to think about with our outcomes, because these patients, even though they now have this new knee, they are not as likely to weight bear and use that side as they are their uninvolved side. And unfortunately, that then leads to the uninvolved side becoming arthritic as well and requiring a knee replacement. So if we can avoid that with this early rehab to make sure that they can weight bear equally and evenly and use their surgical side as much as possible, then we are doing a good job in improving our outcomes with physical therapy. Okay, guys, we'll talk soon for our next surgery. Bye-bye.